Good evening, friends. Welcome to this evening Tuesday sessions of academics from Yashoda Hospitals, from Critical Care Medicine and Emergency. So today we have an interesting session. Many of us, not just the general public, but clinicians' mind, we have many queries related to whether we are at the end of second wave, we are waiting for some more waves to come, or we will have some milder lingering of these cases for a longer period of time. To address this, we have two eminent speakers and panelists, Dr. Dhruv Chaudhary, who has been HOD and professor and the past president of ISCCM. He has been one of the task force in many COVID programs of government at government levels and in ISCCM levels. And the other panelist, we have Dr. Kamlesh, who is our senior internal medicine physician and been a part of the whole heat and the effect of treating almost thousands of patients in OP and IP together with his team. So with this, we will take this panel discussion forward. Sir, we have been listening about many speculations, many models, many things across the globe, and many webinars happening in and around us. So being in the field for the last almost 1.5 years to 2 years, with all the clinical trials and different models of predicting, what is your prediction from this point that do India is expecting a big third wave to come, or we are just probably over projecting or overestimating things? So what is your take on this?
Thank you, Venkat and Dr. Kamlesh, for giving me an opportunity to be all of you today evening. And this is now the hot topic of debate, both within the medical fraternity as well on the television channels. And I think television channels are now dictating the policies and other things. Having said so, yes, we had a very bad second wave. And if you really look at the projection of the second wave, and if you really go back and see the projections of first wave, practically you will see the similarity. They are superimposing each other. That's a different issue, that we used a lot of non-pharmacological means when in the first time. Therefore, that led to the blunting of the wave. And we had peaks and cuffs which kept on coming up. Like in Hyderabad, you saw first thing probably in the month of May, when the Markaz event took place in Delhi and the people went to different places. And a couple of super spreaders even took place within the Telangana, in particular, Hyderabad itself, and at other places. So we have been seeing that relentless thing. And so when the Delhi says they have seen 4 waves, they are not wrong, because they saw it at that time post Markaz. Then it was somewhere slight peak came up in August. Then September we had the worst time. And then around Diwali time, South may not have a Diwali period, but we had expected, and if you remember, we wrote an editorial in Indian Journal of Critical Care, mentioned that the winters are coming, we need.
I think there is some disruption in his internet connectivity. So before we actually again connect him, I will take the discussion forward with Dr. Kamlesh, who has been in the forefront of managing these cases. So we have seen the first wave, we have seen the second wave. We somewhere were predicting many things related to transmissibility and severity. What is your prediction? So we have seen a very bad second wave, which was beyond our prediction, beyond our preparation, and many things gone over our heads. So what is your prediction in this third wave? What do you think the transmissibility will happen? What will be your prediction about the severity of this wave?
Thank you, Dr. Venkatraman, for giving me an opportunity to speak on such a elite platform. Good evening, sir. Dhruv Chaudhary, sir. So, looking at the pandemics over the last few centuries, and especially this pandemic, we are sure that there is a third wave which is inevitable, and we cannot escape that. So one thing we have to understand, the only question we need to answer now is, when is the third wave going to come? It is going to come, but the questions are three with us. One is, when is it going to come? How severe will be the wave, and how big will be the wave? So that are the questions I think we need to answer in this session. And if we understand that, that's because it's an inevitable thing. The first wave was quite a simple and predictable wave with a wild virus, with a gradual wave pattern which started somewhere around March in India, and gradually peaked around May, June, and then settled somewhere between September, November. The second wave, after a gap of 2 to 3 months, started again end of the February, and it was quite big wave, more severe, more lethal, and killed many people, burdening all the resources, both government and private. And now we are in the phase, intermediate, immediate phase, the phase of tranquility, where we know for sure that there is a wave which is going to come, but when, we are not sure. There are a lot of models which have been developed and a lot of studies which have been, and they have predicted that the wave may start somewhere around August. Some have predicted somewhere around August, some around September. But overall, we know that it is coming very soon, somewhere August, and it is going to last up to November, December. How big the wave will be, again, depends upon a lot of factors, including the virus variant, which is going to be a very important factor in determining the transmissibility and the severity of the wave. The first wave was a wild virus. The second one, mostly Delta virus, which was more lethal. The third wave, we are seeing a lot of mutant viruses, out of which one of them might be dominant and might take the lead in the third wave. So if we suspect somewhere around June or August or September, that is the time when we are expecting a wave, we should be prepared well in advance now, and it's not far away that we'll see the wave. So what are the factors which will affect the wave? First thing is the immune population. The first wave, when it came, the population was totally susceptible. The second wave, though there was some immune population because of previous infection, what happened is vaccine was not available. But here we have an heterogeneous population which is both vaccinated as well as infected. If you look, there are a lot of studies, serosurveillance studies, which have been taken place in major cities across India. What they have found is the antibody prevalence in most of these populations, whether it's children or the adults, is more than 50%. So that is one good news, that we have a very good antibodies in the population, which is giving a good herd immunity. Still, our vaccination levels are only 30% of the actual population. What we require to get an adequate protection or adequate herd immunity or to protect the third wave is 60%, which may not be possible by August. So it's better we prepare ourselves for the third wave. And coming to the severity, there are a lot of wild viruses. If you see the R0 in the first wild virus, it was R0 is nothing but the index case causing transmitting the infection to the secondary or on the contacts. It was 2 to 2.5. Then coming to the South African variant of the UK, it was somewhere around 4 to 4.5. Now these Delta and Delta plus variants have an R0 of 5 to 5.8, which means that each person is going to infect about 6 people in his surroundings. So that is one very bad news which we are seeing about the Delta virus or the new variant. Whatever it is, the good news coming in the form of good adequate herd immunity, which has been achieved with previous infection and immunization. And the bad news is that virus is more lethal and more transmissible. So accordingly, we have to prepare ourselves. Most irrespective, if the virus turns out to be lethal and more transmissible, we again come back to our basic, that is taking all the protective measures in the form of COVID appropriate behavior, like wearing masks, social distancing, avoiding congregations, all these things. These are very important. So that is the number one thing. In spite of that, there might be some cases which will come into the community. And here the first idea is to detect the case, isolate the case, first trace them, isolate them and treat them. That way we are going to prevent another 6 infections from that one particular person. So if it is going to be a Delta plus or similar variant, which is more lethal, the first important thing is isolate him, treat him, and then release him into the community. Identify populations or areas which are more than 10% of the population and immediately declare them as containment. So these are some of the targets which have been discussed among the government authorities to prevent the third wave to cause severe havoc. Other one advantage we have with the third wave is that we have now enough knowledge. We have enough understanding of the disease, how it behaves. We know what to do. Earlier, there are a lot of confusion with regards to medications, with regards to...
Dr. Kamlesh, I'll come to that question later.
Yeah.
We welcome you back, Dhruv sir, this discussion.
Sorry, I'm sorry, there was some technical problem.
Yeah.
I think that happened, the wireless is coming now, the net has gone away.
Yeah.
So that's why it has happened. I'm sorry for that.
Yeah, so the point back to you that we now are using some predictable models to predict this different kind of waves. So what are those predictable models which you think have been used, and how do you predict? When are we going to get this third wave? Are we going to get a wave at all? And what will be the time frame and how big it will be?
You see, first of all, we should know what wave is. Wave is mean that you find certain increase. So you have peaks and troughs. That is what we are going right now through the trough. Peak has gone away. One. Secondly, what is important, these cases will go up. How much time duration they will take it up. On an average, what we are realizing is they can take anywhere from 6 to 12 weeks. That's the period. But on an average, we are finding it up to 6 to 8 weeks. That's how it is happening too. The common model which we talk in terms of is called as a SIR model, SIR. And S basically susceptible, I in terms of infected, and R is in terms of recovered model. That's what is for the epidemiological purposes. And there are different mathematical modeling. People say that probably you may have, it may start somewhere from August and peak it around late August or September, because once the wave starts, it's not that it becomes, it gathers momentum over a period of time. So it gives you time to understand and take care of it. Like today, if I see the districts, how many districts as of today are having percentage positivity. So if I look at it, if my percentage positivity is less than 1%, like in Haryana right now, we have 0.09%. So if it starts going up, you start looking at it, one. Secondly, you start looking at it, the number of people who are getting affected in the families, etc., or not. And then you will see suddenly there will be a burst of it, because 50% infections are asymptomatic. Therefore, predictive models are different. The standard, what I told you, they take a susceptible, infected, recovered model, SIR models. And when, everything will depend upon how much susceptible people are there. Now, in the susceptible people will depend upon how many of them had the COVID in the past, A. Second thing, you need to look at it, how many have been vaccinated now, 2. And third, we need to also look at it, how many number of patients are going to have a breakthrough infections, etc. So all these things combined together, the data modeling which is coming up, they feel that from August right up to October is the time. It is this duration, but there are certain other people say there may be a late predictions from September, October. But what my observation has been, whatever the West is having, we are seeing that the thing 6 to 8 weeks. And like UK is following your France by 6 to 8 weeks. And we have been following UK by around about 8 to 12 weeks. So I think today UK is having that pattern. So we should be ready, one. Secondly, within the country, you need to look at the states. They can also give you an idea. You look at this second one which started, it started from Maharashtra. Yes. And it started in the eastern Maharashtra. The first wave, if you really look at the first serious cases, also started from the western coast, because at that point of time, we got maximum illnesses from either Middle East, their transit airports become the point, or we had it from the west, like from UK or from Italy. That's how we had it there. So my own perception is that we will see the rise in cases depending upon it. If I go by the pattern, there it is being driven by the Delta variant now. We have already faced the fury of Delta variant, all right. So then we're talking of Delta plus. I'm not as much concerned about Delta plus because they're all part and parcel of it. We will be now, we are doing epidemiological surveillance of around about 5% of the total cases which are coming up positive. But my worry will be if a new variant we detect and which is highly infective and transmissible. That is what infectivity, transmissibility is there. And if you see also the pattern of positivity on RT-PCR, it will give you a fair amount of an idea. One strain pattern, when they come up the cycle threshold, which we used to be initially confused the CTs for the RT-PCR or CTs the radiology. So one has to spell it out. So if you see initial first phase, even if you remember in Telangana, values used to be around 28, 34, 32. That was the pattern which we saw to begin with. And as the waves picked up or the cases number picked up, we found out the family people were there, but never the whole families by and large. Till the peak of the COVID was there of that particular peak. Now roughly estimate was 1/3 of the total getting people are having it. And then we found out the super spreader events and all. But in the second wave, if you see the Wuhan, then you have the classical strain of which we had 614. Then we started finding it up that we had much more higher viral loads. It spread in DG, which you call it. So that's what spread it out, which one was seeing, and people try to blame it to the markers, that this is what is responsible. And then subsequently, now you see now, that was driving the second force. We didn't have that data of genetic coding there. But now we know that initial phase in North India was driven by alpha variant, which came from UK. But the Delta, the so-called double mutant with the story now, with the LR452 and L452R and E484Q. That is how it started up. And all E484Q was there in Telangana earlier was detected. Yes. And if you see L484R, which is there, 452R, which is there, it is a Californian strain. If you really look at it, it is going on in the California. So point I'm trying to simply make is that end of the day, when they combine together, today it is there. And today when you see it has expanded of 484. Now you have got S1, S2 mutant, and that is what you are seeing is 681, which has come up, which is giving it again a unique ability. This is your Delta strain, which is now 11617.2, which we are seeing. So they have the name technologically.
We'll come to variants because we wanted to hear a lot from you on that aspect. So I think the both side from the local expert opinion and national wide, the experience both says a third wave is inevitable at this point of time. And what we have seen the pattern from United States of America, UK, they were, if you see the first wave in April, May in 2020, then in the January 2021, and another 2-3 months later, we had seen the same kind of second waves and first wave in India following them. And the second part, which you re-emphasized by Dr. Kamlesh and you, sir, the infectivity, the transmissibility, as the variants changed has been very wilder and they have been progressed very badly. So we wanted the whole of the medical community and even many of the parents and families are now worried about the age group. So what we have seen, the first wave, the most sicker group were more in the elderly age group, even though the younger age group got affected. But what we have seen, even Dr. Kamlesh will agree with me, in the second wave, the surge was more between 20s, 30s, and 40s, and more lives were lost in this productive age group. Now we are seeing the more than 60 age group getting vaccinated, even now more than 40 getting vaccinated, and now we are talking about all adults getting vaccinated. So many people have concerns whether the pediatric group will be a prone or exposed, a group which has been not exposed to vaccines. Not many may have also got infected, but we see the families when they get infected, it comes as a, the whole block of the family gets positive. So what is your take in this age group? Will have any difference in this way? What is your prediction on that end?
You see, I think Venkat, one of the biggest myth is that the young people have got affected more in this way. I think it's the biggest myth which we need to demystify. The only thing what has happened during the second wave has been is that it came rapidly. Signals were there. Footprints were there. We did not pick them up. We failed to do that. One. Second is that it came so suddenly that everything happened over 4 to 6 weeks. It came, it conquered, and it went away. That's how it has happened. Now, if you see that, and I will give you the data now. If you see it in the first case load and the second wave, the less than 10 years in the first wave was 4%. Second wave, whatever we had done it, This I am talking about 31st of May, 3%. 10 to 2 years, 20 years, 8% in the first wave, 8.5% in the second wave. 30 to 40, 21% in both waves. 40 to 50, 17%, 50 to 60, 55%. And similarly, when you look at the death rate, there was no difference. So it is a myth which needs to be busted. As many numbers, the only difference is in a short span of time. You have too many people. Therefore, what you saw over, let's say, 3 months or 6 to 8, you saw over 2 to 4 weeks to 6 weeks. We saw it from the middle of April right up to end of May, because the peak came in the first week of May. I think that is very important. And because that is the whole concept of the management of COVID was, first to prevent it, if it happens, blunt the curve. We were not able to blunt the peak. That is why we saw 4 to 5 times high. In the first time when happened, we had the very strictest of the lockdowns there. Here, where was the lockdown? Everybody was moving around. The younger people were the vehicles and the carriers and spreaders in this case. So yes, absolute number, large number of people young died, no doubt about it. But when I look at the percentage of the people affected, there was no difference. I think there has to be clarity on it. In percentage-wise, answer is no. In terms of absolute numbers, answer is yes. So when we talk in terms today, the data is showing 50-55% children already are getting infected. So I think probably what we need to realize in this service is that it is very secular in its trend to affect people, A. Most important component is the unvaccinated people will be infected more. And today the data has come up from Armed Forces Medical Journal from India. They are showing unvaccinated people are 7 to 8 times more getting the disease than partially vaccinated or fully vaccinated. Still the number goes down. Therefore, it will depend upon the susceptibility of the persons or the population, one. Secondly, whether children or adult, it does not make a difference. But when you see it, but yes, I do agree, with the vaccination program, you will have a much more elderly people or the people more than 18 now getting vaccinations, one. Majority will be partially vaccinated, not fully vaccinated. Then you will have a children, which again 55% have been there, they constitute 10 to 20% of our population. So probably I expect that vaccination program will take over, but short of that, to say that children will be much more effective because they have the capacity, capability, and majority of them are asymptomatic. The only thing which we need to be ready in them is to identify multi-system inflammatory syndromes that we need to pick up. And remember, that is not only for children also, that is for adolescents, that is also for young adults, which are coming up to you. You need to be careful about it. Otherwise, we can miss them in elderly or in the young adults also.
The multi-system inflammatory syndrome is typically seen in the adolescents, maybe 10 to 14 or that age group, more than these toddlers or more than these infants. This has been, the pediatricians has commenting more on it.
The West is average age of the most of the publications between 7 to 8 years or 10 years. But this is the time, because majority may not be having much of a disease process. That is where the challenge comes up. So when they come up to identify those people, because disease may be asymptomatic, minimally symptomatic, or sometimes children ignore it. That is the only thing. But I do agree with you. Less than 5, if you see less than 4 toddlers and all, mortality is minimal. We are seeing in epidemiology coming, it's hardly, it's there. I'm not saying, but still it is minimal.
Yeah, even from UK, they are now in the peak of the third wave, or maybe the wave is tiding down. The information from their experts, even in the recent interactions, what has been seen is not many pediatric ICUs or many pediatrics IP has been overwhelming there, even in the third wave, where most of them are not vaccinated. So the prediction, what we were now thinking, that pediatric population may be a target population in this wave because they have been not vaccinated, but the infection rate, as you rightly pointed out, was almost the same because in the family, all of them got infected. So coming back to Kamlesh sir, every drug has been used in COVID. Name a category like anti-malarial, anti-helminthic, antiviral, antibacterial, all vitamins, all minerals, all antioxidant, all immunotherapies, all MABs, everything. We have gone through almost a year and a half of time. So you being the clinician in the front line, what is your learning curve and what is your actually take home, how you are preparing yourself, at least as from the treatment protocol wise or
the
management
treatment
wise?
part. So it all started in March when we were very new to COVID, and whatever data we had was from China or from US and few of the European countries. And that time we did not have any available drugs. And you know very well, Dr. Raman, that we have treated patients without anything. Patients were just admitted, being given a very small dose of steroid, if at all. And then the slowly lot data came on each and every drug. There are almost 400 available drugs which have been studied in detail and extensively. And each drug has been uploaded or approved one or other time. Finally, all these drugs are out. So what we found out that almost there is no specific drug other than probably the monoclonal antibody which has been used. And second thing, the role of steroid in the low molecular weight heparin. So with the first wave, we were treating patients only with steroid and heparin with other supportive medicines. Sometimes we started using ivermectin. As we went to second wave, we had availability of every drug. We started using this immunomodulators in the form of TNF antagonist, IL-6 antagonist, then bevacizumab, etc. But more and more studies have told that they're more harmful than useful. And so probably in the third wave, that approach will be slightly different. We'll be using the same drugs, but the dosage, everything will change. First, we will come to the dose, the role of monoclonal antibody. There is one drug which has been used with good results if it is used in less than 7 days. So the role of monoclonal antibody would be a major one in the in the third wave, provided the patient is affordable. Coming to the second drug, that is remdesivir, whether it has been approved or not, useful or not, but I think we will continue using remdesivir for whatever reasons. Coming to the oral antivirals, that is favipiravir and molnupiravir, we have one drug available, but in outpatients, we will be using that, I feel, because of multiple compulsions. Steroid dose, we have used excess of steroids in first and second, so we know a lot of negative side effects, what happened with steroids, whether mucor was related to the use of steroid or not, it's still unproven. But I think now we know the timing of the steroid, better to avoid it in the first week or at least first 5 days of the disease. You know when to start, how much to start, and when to stop. So that is one thing. And the role of heparin, anticoagulation role, then the role of thrombolytics. So this is going to be the major area where which will be the focus in the treatment aspect. One is anticoagulants, second is thrombolytics, use early to prevent thrombosis and everything. Then use of remdesivir, monoclonal if patient comes in the first 3 days, and steroids. This will be the main drugs. Coming to other supportive drugs in the form of vitamin C, there are a lot of data on vitamin C, vitamin D, ivermectin, use of zinc, N-acetylcysteine, etc. So I think those drugs will be used without any harm. I think we will be continuing to use.
So you
but immunomodulation, I think we will be less aggressive on the immunomodulation because we have learned a lot from that, what we have used, because out of compulsion or out of non-availability of remdesivir, we are forced to use immunomodulators. Some drug we have to use. So we had to use that one. So probably we'll come less on this immunomodulation.
So Kamlesh sir, we have actually come at least to a learning point that we have narrowed down to very few drugs right now from a list of maybe 30, 40.
Yeah.
We're talking about a moderate dose of steroids in 5 to 7 days and anticoagulating them, and maybe remdesivir in appropriate cases and tocilizumab in indicated cases. And the rest, all drugs are now slowly got into rest, and you have a monoclonal antibodies combination in early phase of this disease. That's where we are. Dhruv sir, are you there? So, so the monoclonal antibody usage, if I come to that monoclonal antibody usage, sir. So Dr. Dhruv sir, I have been hearing you from the first wave onwards. Whenever we spoke about the steroids and other things, you were in very particular that Dr. Venkat, viral phase, and then you will have an inflammatory phase. And when you come to those stages, antivirals should go in combination with some form of this anti-inflammatory like steroids. You remember those days, sir? Those are early days where you, in all webinars, I still remember those insisting of you. So do you think that still counts here now? Antivirals, remdesivir, gone in, come out, gone in, come out. You still believe with that concept in the third wave too?
We saw the quackery at its best as far as things are concerned. And at the same time, there are certain things which we need to be very, very careful about. First and foremost is, you see, basic of pathophysiology, we need to follow it up. First of the basic of the pathophysiology, as you very rightly said, is viral replicating phase. Then the immune system will start coming up, and then the inflammatory phase starts. And then depending upon how the host responds, on the basis of that, along with the virus strains which are there and its experiences, you will realize it, whether person is going to have a cytokine storm or a severe form or not. Because out of 185 will not have anything. Now that is why a large number of treatment people are claiming to be successful. And one of them, first and foremost, is ivermectin. Now data still shows some of one or two meta-analysis that it does affect, and it probably helps early recovery in terms of RT-PCRs and all. For me, that drug is effective in the first phase, in the viral phase A, which is a potent antiviral, and not only potent antiviral, but also ensures that there is no pulmonary or complicating phase. That means it cures the disease itself in first week. If I get RT-PCR negative and I am satisfied, but people land up with again respiratory failure or other multi-organ dysfunction, it's no good use to me, one. Secondly, I will also like to have a drug which prevents multi-system inflammatory syndrome like complications which can happen. If that is the one which you want to use it, fair enough. And monoclonal antibodies now have been shown to fill in that bill in two groups of people. A, when you use it in the first phase, where they have been shown to reduce by more than relative reduction by 70% of these cases, whatever is available with us, depending upon the timing which you are using. And secondly, which again is the recovery trial data, that in the serious cases who are on ventilators, there if you have a negative antibody profiling in that case, and if you use monoclonal antibodies, recovery is faster. And in fact, that is the first antiviral trial happened to reduce mortality. Now that reduces by around 20% in that subgroup of patients. Now the crux says, it tells something else. So you need an antiviral when the people are having a severe pulmonary and other phases, or where they're getting organ dysfunction. Remdesivir, we are trying, the data shows as per the ADAPT trial is, as per the ACT trial, which is an adaptive trial. You use it early, you get a better result. You use it, and again, there is a thing, they found the maximum advantage where hypoxemia was there. And when the patients are on a ventilator, they try to reduce the duration of it, but they have no effect on mortality. And again, the target is to reduce mortality, but at the same time, if you reduce period of time. So remdesivir, if you see the in silico or in vitro data, is not as potent an antiviral, but it is the maximum which was available to us at that point of time. So remdesivir still will not go away. People will use it as an antiviral drug. But having said so, we are looking for large number of new molecules which may come up. And one of the drugs which we are also doing a trial, as of now, Iran has used it, is a repurposed anti-hepatitis C drugs. Especially in this, if you see on in silico data, that is on computer modeling, when you see, in fact, the best drug coming up is the ledabosepril. And then you have a Decla, then you have a Sofo, and all these three drugs have a better profiling along with their metabolites than remdesivir. The only question is we need to do a long-term trial. Similarly, you're seeing molnupiravir. The trials are going up in the initial phases.
We are doing, sir, we in our institute unit are doing the molnupiravir trial for the OP.
Yeah, but important is not RT-PCR. They are fine in terms of transmission of infection. What is important is, can these drugs, when we use it first, prevent complication?
Yes.
If they do it, it does. Like oseltamivir, if you use in flu, in first 48 hours, they've been found to be effective. Later on, all of us have discussed a different meeting. It has been futile. People have been doubling the doses without any having out effect. Therefore, it is important. And third thing which will be important along with this, the strains, we have now started talking about like antibiotic resistance, antifungal resistance. And when you look at it, the viral strain which will come up, the sensitivity, susceptibility of that.
Dhruv sir, I will specific to that and will ask you that we are talking about, even I was talking to Dr. Kamlesh just before this session, this monoclonal antibodies. Right now also we are talking about the new variant, which you say Delta Plus or even a Delta variant may have some monoclonal antibody escape phenomenon where the effectiveness may get some hampering. What is your take on that?
You see, there are two groups of monoclonal antibodies which are available now. One is L-Lily, another is the Regeneron, right? I have experience limited with L-Lily and much more with the Regeneron because they were given to us in the state as a state nodal officer we have been provided.
Yes.
I used Regeneron, one which was available to us, a 93-year-old person. And we have used it up to 54, 55. And the last week only we used it in a person who is 38 years of age with a comorbidity. Now, these drugs, fortunately, all of them have done extremely well. They had a significant comorbidities. Having said so, the data we need to see to get a definitive result, we need to parallel think of more than 800 to 900 patients in our own context, our own country. One. Secondly, when you look at L-Lily, it is a combination of belamesivimab and another one molecule. Belamesivimab was withdrawn from the emergency use authorization because of its lack of efficacy. Therefore, it is, just hold a minute. Sorry, my dog came inside.
It's being a part of all of us.
That is why I had closed at that time. It was sitting closely with me. I think the maid came. So it's its eating time. Sure. So that is what it is there. Now, what is happening, the difference between the Regeneron and L-Lily is because both casirivimab and vidofludimus, they work on different domains. Whereas, as far as the L-Lily, the two drugs cocktails which we're using, they have a crossover. They cross over, so they share few domains together. Therefore, theoretically, the Regeneron has a far wider range, which is there. Now, escape phenomenon definitely will take place if we find a variant. Because if you will put a monoclonal antibody pressure on the virus, it's likely to escape one. Or there may occur some de novo variations which can also escape. But now they know the trick, probably they will modify with it. And we know that the dosage started from 7,200 milligrams have now come down to 1,200 milligrams. When I say 1,200 milligrams, 600 milligrams of each, which can be given both intravenously and subcutaneously. So this will do it. And second component, which is now coming up, is hyperimmune serums. Like we have been using ASV as other, the trials are going on, and data will show it. We have one of the centers, but there are no patients now. So I think all of these things will come up. And let's see, it is something like, and then people are trying to use it also as a preventive medicine, so that if one gets exposed, may not get it. But I will not go as far-fetched because when these epidemics comes, we do try to take it up, but they have their own pluses, they have their own minuses.
So you have raised a point of dosing, sir, and also you have raised it is not preventive also, or not in the initial phase, but in the severe on ventilated patients also. The dosing there they recommended is 4 grams each. The dosage is very extremely high, maybe 8.
There is a difference when you treat it early and when you treat it late. Now they had no clue. They started with that initial high doses. Gradually, you see, these still are early days. They used it in recovery trials, so now they have come up. The doses which have been extremely high, so the cost jacks up.
High. That cost goes up to 4 to 5 lakhs, not the same of 60,000.
But you see, we are talking right now as a science, and then we come to the economics of the treatment.
Okay. So now coming from this escape phenomenon, sir, we have seen now believe also that most of those population who has been walked out of the home in the second wave got infected, either in the asymptomatic phase, or I believe it's a good percentage of population got infected. And now we are having a data that at least 20 to 25% of Indian population getting infected or getting vaccinated. So putting together, if I believe we need some number somewhere 50 to 70% of population to get immunity, either through a natural infection or either through a vaccine. What do you think these new variants are doing, which we see even in the second wave, we have seen few cases which came after the 2 doses of vaccines. And also we have seen few patients coming after the first wave infections. What do you think this immune escape is doing? Is there any
See, immune escape is not to be there. You see, you have to remember, biology is not linear. Biology is non-linear. That is the first principle we have to agree to. Secondly, like I'm sitting in front of you, I tell everybody, I had COVID in the first wave also, I had a COVID in the second wave also. So because of when we looked at it, was the Delta variant now this time. And I'm vaccinated also. But what is the advantage is that when you're using vaccines, I will start with that. There is no vaccine as of now which gives sterility, complete sterility. That is full sterile safety, nothing. That only will come through if we have some nasal ones which are there. But the only problem with most of the nasal is that they may not be live attenuated. They have their own challenges, like we had seen it with influenza or other things.
Yes.
One. Secondly is when these immune escapes phenomena are taking place, they are bound to take place because the genetic construction things, they go up. When you are using molecular areas like spike protein, we are taking a part of it, and then depending upon the domains we are doing coming up. If you see the data which has come up with the Pfizer as well as with the Covishield published in New England Journal of Medicine, single dose is giving both 31% and 47%. Combined dose 88%, 65% respectively for Pfizer as well as Covishield as far as the data is concerned is there. Number of cases have gone up in UK and they say we are very happy, not much admissions. So I think they will be there, cross reactivity will be there. And my own feeling is that the whole viral genomic structure will give you far better protection if we can do it. But unfortunately, we are not able to do that. And it is also a fact that when you're using vector vaccination, theoretically, the same principle what we are using at the nasal sprays and all, they always tend to give a much better immunogenicity because they can replicate. But now to prevent secondary infections, etc., we are using non-replicative ones. So these are the normal natural immune phenomena which will keep on happening, and it is much more prevalent today because of vaccination being done in active disease context. Now, I will not be lying idle saying that I vaccinated people. I have more than 70%. We have herd immunity. Look at it, what has happened in Brazil. People are 75% in that city, and they've been just marauded. You are still at 25% because the principle is that if nearly 2/3 plus, if you have a highly infective strain like Delta variant, which is 1,000 times more loads and which is more than 60% infective than your Alpha variant, where are you? Therefore, I think we have to, from the principles of as a policymaker, I would like to go for the vaccination status as we go for the measles. So
what is your take?
The larger number will be required than simply 60, 70 because we are all doing mathematical modeling thinking that everything is linear. I won't go by that.
We will take Dr. Kamlesh's opinion, sir. Dr. Kamlesh, what is your take on this immune escape concept? And you have seen patients on both the sides. What is your take on that?
Personally, at the level of my clinic, what I have seen about 30 to 40 patients who have been infected earlier in the first wave and got reinfected. And as sir said, he has also got infected earlier.
Yes.
Second time, in spite of vaccination, he got
infected. Yes.
So definitely there is an immune escape phenomena, either because the virus is mutant or it's escaping the antibodies which have already been developed. So it is going to happen even with the third wave, and we have to be very careful, not being confident that we are vaccinated or we have got previous infection. And immune escape is a definite phenomena which will happen. I feel that it's going to be there.
Okay. Sir, what we have seen right now in even UK, the number of cases in the last 2 months has surged almost equivalent or more than the second wave, that closing to 50,000 or more. But after the good percentage of population got vaccinated, the hospital admissions, in spite of such a high positivity of 50,000 or plus, has been very low compared to the second.
Mortality also has been very low.
So that means you believe that the vaccine, even though there is some immune escape, the vaccines and the herd immunity in second wave and the first wave is playing some role to give us some immunity to the at least severity and hospitalization, even though the positivity remained to be high?
that is what the theory tells. If you are vaccinated, if you have got previous antibodies, if you are definitely, it is going to protect you. And we are also seeing, even as you said in the UK, you are seeing there are a lot of cases who have occurred with the deaths. And really speaking, the vaccinated people, the incidence was less than 0.003% or so, compared to the non-vaccinated people, which was around 3 to 4%. So definitely the incidence of infection is almost more than 1,000 times in non-vaccinated, non-infected previous people. So it is vaccination is going to help. And the main idea behind preventing the pandemic, stopping the pandemic, is to vaccinate or acquire and herd immunity of more than 60% of the population, either way, either natural or in the form of vaccination.
There were some discussions, Dr. Kamlesh, related to the RT-PCR coming negative in some of the cases in the second wave, where we have seen the CT being typical of a Corad 5 with a negative RT-PCR and being hypoxic, the clinical features matching.
Yeah, there are few studies where they said that the virus disappears even by 5th or 6th day. In spite of the disease progression because of the immune response, the virus may not be there, and 74% chance of the virus disappearing after 1 week. So maybe what we were doing is we are doing taking the swab quite late in the disease. So that's why one reason maybe that one. And second thing, probably collection of the sample was not proper. That's the only two reasons I think. But the probes we were using were quite adequately covering 2 different genomes of the virus. So we should not have missed it by way of the proper sequencing that we were doing properly. But if we are doing it late in the disease, we might miss, because the viral load is very low. In that stage, it's more of immune related damage. We are seeing people coming with ARDS, coming in the late stage of the disease. We are missing because of the low viral load.
So
what do you say, sir?
Yeah, Dr. Dhruv, what is your take on a diagnostic escape?
You see, diagnostic escape, what Kamlesh has said is very right. And something interesting phenomena, you must have seen it come from England. This is how they detected the first variant. They have been doing large number of sequencing and other things from the beginning. They have the resources and other things, but I think it's a question of mindset also. Having said so, they found, what did they find? They find that they found that S gene when they were putting in terms of detection of the Thermo Fisher test, which they were not able to have it there. So they were doing all 3 genes, and that's how you found out. So if you're doing a test and that particular test, the variant escapes, then probably you may also have a negative detection. So that's how we had actually proposed in our state government also to have a test where we can test along with ORF and E genes, etc., an S gene or N gene, which you are doing it. So when you do all 3 genes, the cost does go up, but you can detect actually certain specific variant even without doing sequencing. So that is one advantage of it. Rest, everything is the same, but nevertheless, it's timing which was there. High viral loads will always be picked up, because this time we had a far steeper or quick peaks which were coming up as far as the RT-PCR was concerned. Earlier we were seeing a gentler slope. So everything brings down the pre-analytical, analytical and post-analytical issues which are there. We need to take it from that account. I think what Dr. Kamlesh said fairly holds true.
So, Dr. Dhruv, right now we have been listening about this variant. We started with wild, then alpha, then beta, then we spoke the last rampage in India was delta. Then now we are again talking about delta plus. So anyway, the RT-PCR only says whether you are COVID positive or negative. And we are now also talking about the prediction at zonal levels, not at country level, state level, or at international level or zonal level. And this variants and this transmissibility, infectivity, and the prediction all being concerned now. So do you think these variants, there are many variants, but as far as the WHO, CDC, and government officials, we are now leveling them, the variant of concern, the variant of seriousness. So what do you think this variants has a role to play? And we all keep an eye on them when we see a sudden surge on these variants. What is your take on these variants? We are listening a lot of rotational variants.
Let's accept it that virus is going to mutate. It has to survive. And now normally it divides pretty quickly. Therefore, the probability of getting mutations are much easier and much more likely than the mammals and all places. That is the part one. Part two is for me that will be concerned if like, let's give an example of Delta. You earlier had the D614G, which was there with you. Now, gradually, when the cases started coming, you realize there is a dual mutation. Similarly, in England, they realized that there is the Kent variant, which is now called as alpha variant. It is rapidly increasing and doing it. That means if you find that the variant has more infectivity, that is one part. Second is when you find there are large viral loads which have started coming up. Third, when you find out the more number of people in it are starting getting complications than the expected numbers, then for that that variant becomes a variant of concern for me. And then obviously the immune escape phenomenon when you're finding, and within the lab now we can do a testing and we can find it out whether on the lab testing on serology, whether this is responding to the people who are vaccinated or not, or the so-called immune escape lab phenomena you see it. If you find it, then I'm worried, I'm concerned. Yes, this is a this is a variant of concern. If it is not, as has been said, virus aware, it will be variant of interest, which will be coming up academically. You keep on adding to the library, and when you do, and then you do a genomic sequencing, it will help you in terms of epidemiological or molecular surveillance or molecular epidemiology, and you can trace it up like people have been doing for avian influenza for so many years.
Dr. Kamlesh, we are now should accept that there are a lot of concerns, doubts in the safety of vaccine. So we have seen that pockets of information being spread across with the occasional on and off pockets of complication related to the thrombosis, related to the thrombocytopenia, occasional transverse myelitis here and there. And these safety concerns are overblown. And there were a lot of innovation also in some of the general category, even I will say some in healthcare category also. But what is your take? Is the vaccines answer for our further innovation of these waves? What should be the way forward? How you take the vaccine as an important lethal weapon to stop these things?
Vaccines definitely have got a role in preventing or stopping the pandemic, because those are the only way of achieving a adequate herd immunity. We cannot infect 70-80% of the population cannot be infected, and we cannot wait for that. So we are supposed to vaccinate our population. The next question comes is, which is the best vaccines? There are a lot of vaccines available right now. Pfizer's vaccine, then Moderna, J&J, Covishield, Covaxin, a lot of 8-9, China, Sinovac is there, Russian, Sputnik is there. But in India right now, we have 3 available vaccines, that is Covishield, Covaxin and Sputnik V. We do not have any mRNA vaccine. They are supposed to be having good efficacy, but our vaccines are giving an efficacy of around 75 to 85%. What we need to know is all the vaccines are safe, and whichever available is good. And if you look at our data, our hospital data, till now, we have immunized almost more than 1 lakh people, and we haven't seen any thrombotic event even in a single person. Even across the world, the Covishield, the AstraZeneca vaccine, the chances of thrombosis are less than 1 per lakh. So I think we should be very clear that thrombosis is one of the side effects, but it's not a major side effect. Maybe some other risk factors, associated factors are responsible for that. Now coming to the question, which is the best vaccine? It's very clear availability. We do not have availability of Pfizer, Moderna and J&J. So those 3 are out. We do not have availability of Sinovac, so that is out. We have with us only availability of Covishield, Covaxin and Sputnik. All the 3 vaccines are equally good, and I think we should go for whichever available vaccine is there, because they are offer a immunity of about protection of about 75 to 85%. It's not the protection, but it's the prevention of serious infections if you are infected, if at all. So that is what has to be stressed upon the population, that it's not going to prevent infection, but it is going to prevent serious infection in case you have an infection. That is more important. Then price-wise, almost all are in the same price tag, around 700 rupees if you buy in a private place. So we should go for it. And my take on vaccine is that every person, every individual of the nation, including children, have to be vaccinated as and when the vaccine availability is there.
Okay. Sir, Dhruv, sir, there have been a lot of now information coming across that due to many reasons there was an overlap, and now we have understood that the mix and match heterologous combinations also been proven to be more effective than the homologous. The initial attempts may be due to unavailability, but later on now we realized that a mRNA sought after a vector-borne adenoviral, the Covishield may give a better immunity than just the same homologous two Covishield vaccines. What is your take? Suppose in the future we have availability of all the vaccines, including the mRNA category and even the Johnson and Johnson variants. Should we all be looking forward to take a booster by an mRNA vaccine? Will it going to help us? What is your take?
You see, again, what Kamlesh is saying, trust me, Covaxin is far better than what you are seeing the Chinese vaccine. I have been a part of the trial. Let us have a faith in it. And in fact, the data which we are showing, it's a public platform, so I will refrain from saying it. It's very, very encouraging. In fact, if you really ask me, and looking at the complication which we have seen in the patients who have got with the Covishield as well as the Covaxin. I am the member of the Adverse Event Committee also.
Yes.
To say that we are not seeing thrombotic, I think we are only befooling ourselves. I will not go beyond that. We have seen cases where things are there. And if anybody has been given vaccinated, get a thrombocytopenia, be very careful. We are just forgetting one basic concept. We are giving two viruses, genetic material, not one. And what adenovirus is, that is the reason that the second shot is not coming as effective. And also to go with an idea that messenger RNA are absolutely safe. They are very safe vaccines. From the public health perspective, no doubt. But from the individual perspective, you can have it now. We know that more than 100 cases of myocarditis, you miss it, the number is so.
Myocarditis.
But we need to be careful about it. Whenever you are injecting the foreign material, you need to be careful about it. I've seen every sort of challenges you can think in terms of it with the vaccination and their adverse event. I will not state more than that, but you can expect anything in any individual depending upon how host responds. I think that is one thing which is very important. Second,
one thing I came across was that Pfizer is updating its vaccine and including some other sequences. So I think the people who got these two shots might require another shot of a new vaccine. It's probably updating it next month or so.
All vaccines may be updating.
I'm coming to that. I'm coming to that. The mix and match when you're talking about, let us see, science is one aspect. There's a lot of economics and politics into it. And from the scientific perspective, if you really ask me, today, what is the efficacy of we are discussing as a science of Covishield, whatever the data in the public domain, after 2 shots against Delta virus is only 65%. What is the claim of a Covaxin in terms of looking at it, in terms of having it against the Delta is 65%, practically 90%, they're saying it, 93% not having a serious disease. So I think let's not befool ourselves. We need to go ahead. A lot of politics, a lot of economics, a lot of other things are coming into play. So let's go with the science first. Secondly, now you're talking of mix and match. The phenomena is not new. People have been talking about it. And as a pulmonologist, we are using a lot of pneumococcal vaccination conjugate with or without your polysaccharide. One to take advantage of the breadth, another is to take advantage of the robust immune responses. So that is the way forward, no doubt about it. But as of now, the WHO has recommended against it, A, because the data is evolving, and B, whatever has been published in the New England Journal of Medicine, they have shown it to do well. So probably one of the major reasons why people are thinking mix and match are two things.
Availability.
To gain acceptability of the wider thing, and at the same time, to boost the immunity.
Yes.
No doubt messenger RNA is one of the most potent weapons, but this is the largest trial going up with them. Why they are needed? Because they're relatively easier to make up in terms of genetic manipulation or biotechnology, and they can add the sequencing. On the other hand, if you have to use the vector-based viruses to improve it, you have to cut it down, because within that nucleus, you need how much you can put into it, how many kilobytes can come up. If that is how the replicative become non-replicative. And I think the time is also coming, and I'm saying it for the first time, we need to see how much adenoviruses, antibodies we are producing, and how many chimeric molecules are coming. Because I know people developing optic neuritis, I know people developing Alzheimer's syndrome. I know people developing venous thrombosis, and I know people dying. So the government data is in a public domain. But having said so, it is important that they are much, much safer option as of today, because it's a risk-benefit ratio. If you get infection, how much you get it. If you take vaccine, how much problem you're going to have. I think that's bound to be there, but the future will be, studies are being done, and I know people have been given Covaxin and then given Covishield, etc. Same thing you will see in the Sputnik, because they're using entirely a different group of viruses, 23 and 5. So it is important because the second dosing are becoming difficult. Covaxin has a huge supply chain issues which are coming up because of the process in which it is there. And the spin-off, which we must also remember is, if we put everything to COVID, what will happen to rabies vaccination tomorrow? Which is, you see, there are multiple issues which are spin-off. We are all becoming tubular with the COVID. But from the public health perspective, that is important, that is a priority. But we must ensure that in the process of doing so, in this cacophony, we don't lose perspective of the universal program of immunization and also other diseases which are as important.
Yeah. So, Dr. Kamlesh, I think we're coming to the end of this sessions with the limited time availability. So I will just like to take your final comments on last time we were talking about the same transmissibility and infectivity, and high transmissibility, high infectivity made the curve such a stiff that in no time, in a week or two, we actually reached to the peak, and that continued and hurted us badly. So as a department, as a team, how are you actually wanted to prepare yourself, and what will be your guidance, if at all, in the future, which we may not able to predict exactly, even though the severity and the hospitalization we wish remain to be low as we are seeing in the Western world, but our vaccination percentage is not that as great as in the Western country. If at all we get a surge, so how are you prepared? How are you managed? Yes.
As you know, the first wave was very predictable because there was a lockdown period. We had a time of 1 to 1.5 months. It was predictable. We had sufficient time, but we were not prepared. We were not knowing what to do. People were not prepared. There are a lot of healthcare professionals who dropped from the job, who went away, who resigned, including nursing staff, paramedical staff, and our own doctors. So that time it was predictable, but we were not prepared. The second time, what happened is we were very much prepared, but it was unpredicted. Suddenly, the wave came suddenly, and the resources were overburdened. That was third. This time, what has happened is it is predictable, and we are well prepared also. We know when the wave is going to come. It will maximum 1 month here or there. So we know when the wave is coming, somewhere August or May. And in case we can take up the load to any extent, that is what. How we have prepared our department, we have trained our staff. As you know, Venkataraman, very well that we have been training our staff very well. So our staff are more well prepared. They know better way how to wear a PPE mask, how to treat. They know the medications involved. Most of the nursing staff or paramedical staff.
How are you triaging? How are you triaging?
Yeah, that is one thing. Second thing, earlier what used to happen is any positive patients, we were not knowing whether to admit or not. Whether to admit, whether to give, it was all not clear. Now we have developed a triage system where we know whom to admit. So we are triaging basically patients into 4 different categories. A domiciliary treatment where the patient goes home, takes medications and follows up in the OPD. The second group of patients who have risk factors, who have fairly advanced disease, who are going to progress, we are admitting them in the rooms and treating. The third group of people will be serious patients who are obviously kept in the ICU. And the last group was quite serious ventilator patients. So we are triaging the patients whom to admit, whom not to admit. Even triage in the time of the discharge. Earlier, what used to happen is after the recovery, we used to keep patients for 4 or 5 days, which is taking up most of the beds. So now we know that once the patient, we know the time period when now the patient has started improving, we need not keep the patient. There is availability of home concentrators, oxygen concentrators. So we are discharging the patients early. We are admitting patients at the right time. We are discharging the patients quite early. That way we are able to get double the number of beds what used to happen in the first year, second wave, early second wave. So that is one thing, but we have made a lot of changes. Our staff are trained, our people are trained. We have a lot of other people, like we have now COVID care centers like, rehabilitation centers, which have been converted to COVID care centers, which happened during the second wave. So we can shift these patients to those kind of centers without burdening our hospitals.
Yeah.
So that's what we have done now.
So Dhruv sir, yeah, second wave is not just about doctors, nurses, or healthcare system. We have seen many things happening in the second wave. We went awake to an extent that we, in a country like us with a population of 140 crores, we gone out of stock of steroids. The basic drugs in anticoagulants were not available in many centers. Oxygen was a havoc in many times. I still remember we all were doing oxygen stewardship, how to avoid the oxygen wastage, and we avoided high flow nasal cannulas in many situations, and we tried to actually optimize the oxygen. So those were all kind of a nightmares to many of us, where we were just waiting for an liquid oxygen tank to come and fill and all that, with 700-800 patients in the hospital with 400 oxygen beds. So what, you being in the government setups, you being in the administrative positions, what went wrong in the second wave, and what we should be taking the adequate, at least the strategies and measures in this wave, if at all we are coming to face that?
You see, in the first wave, when it had happened, there was a determination, there was a political will, and administrative actions which were taken, which led to it. Second, we were overconfident, we were euphoric, and probably in the mood of elation. We just forgot the ground reality. Footprints were there, if they were ignored. Basic principles of, it's not that the government has not sent the people at different areas, but at the same time, the state governments thought, taking clue from the government of India, that probably, the way the commentators were talking about, that we have conquered it, without realizing that still in the intensive care units, we have not been able to conquer the bacteria. What to talk about the viruses? That was one part. Secondly, we had forgotten there was a fatigue which had set in. People just thought that there is no tomorrow, so everybody enjoyed it. Third thing which has happened over a period of time, which we look at it, is that there was, it was like a cloud burst, or you may say it was a blast, and then a tsunami happened. So every system got overwhelmed. The whole idea initially was, as I said, was to blunt the peak. Here the peak came. And peak, if you really look at the data hard, it was practically the same which was predicted in the first time. We are seeing 4 to 5 times. Our ICUs, they were overwhelmed, ventilators overwhelmed, and there was a wrong priority on ventilators. The priority should have been oxygen. It's not that the last time it has not happened. It did. I remember a letter coming from one of the manufacturers telling to the institutions that they will find it difficulty, because remember one thing, India is not a uniform country. And again, you will have certain oases, you will have certain rough patches. But as a part of policy and planning, you have to ensure that your supply chains are maintained. And even when you did try, you had the adequate capacity of oxygenation. Problem was the turnover times which were needed and which was required, and dominantly it has been towards the east, and wherever you are seeing much more plants of steel plants and all, where liquid oxygen is a component of it. Now, the lessons have been learned. Now, again, if you have a liquid oxygen or you have other thing, if you don't have adequate filling stations for your cylinders, it will happen. Now we see it, and LMO has a 99% plus purity and other things. Now with the PSA plants which are being put it across are having 93% oxygenation. And but nevertheless, if you see it, 500 liters, 500 LPM per minute is good enough for nearly 240 to 250 beds with the 40 intensive care units. And we have not gone into again an academic debate to use it or not to use it for there. But nevertheless, when you are seeing these positive pressure swing adsorption techniques, they're pretty good at it. So they are the ones which are, so I do not expect oxygen to be as much a challenge in the things come up like second wave one, because we are all increasing our capacities. But nevertheless, the population is so huge, it can overwhelm whatever the system, even in the best of the world, in the Western world. Look at Italy, look at UK. What we now need to know is a good control and command structures on the pattern of armed forces, where I know that which bed is available, where I can direct it. So you need to have a hub and spoke models where you have centers and you can move ahead. Third is that, yes, we need to optimally utilize large number of oxygen concentrators which have come up in the market. So they can be effective in the corona care centers, not in the hospital. Up to 10 liters, you can work it out with them. And probably what will be very important, as you said, there was a remdesivir shortage. We did not face any shortage of steroids in the north. I think panic buying was there. Oxygenation shortages, etc., were there, even in our state also. But we fortunately were able to manage it somehow. Then the drugs. The basic problem in the drugs, 3 drugs which have created major problem, was the tocilizumab, remdesivir, and later on your liposomal amphotericin B. These are the 3 drugs which primarily created issues. And we saw also a huge surge of mucor later on. For the people, it has been fun, but we have been seeing it not only as a part of critical care, but also being a part of internal medicine and other departments. It is not, rhinocerebral mucor is not an uncommon thing in diabetics. And India as such, throughout the world, has a higher incidence. At PJ Chandigarh, we saw a lot of renal mucor, which has been there. I think what is important is remdesivir, optional. You need to use optimized in patients who are hypoxic. I think that was one part which was there. The tocilizumab data, we are seeing it. It has been showing that if you use it as topping up or with steroids, then it is effective, not otherwise. And again, if you see the odds ratio, probably 0.86 is there in terms of mortality. That means 14% advantage is there. And if you look at the BMJ article, optimal utilization, one life saved with 25 given, which is a pretty big cost. But nevertheless, right selection, right timing is the key. So you need to demonstrate inflammation plus physiological evidence of it.
Yeah.
Now, another drug which we found some amount of challenge was baricitinib. But now again, baricitinib has come in thok rate and plenty of it now. We can use it, costs have come down. And they have been, our paper has now been published, tofacitinib, in Indian Journal of Critical Care Medicine. It was a retrospective analysis. So now there are things, what it leads to is that you need to now have a clear-cut protocol in place. No additional use of drugs or quackery, I will say. You look at it, what were the 4 prescriptions were there in the beginning? Azithromycin, doxycycline A, antibiotics, favipiravir and ivermectin, these, and rest everything, and if given anything Ayurvedic, which you will do, and people were prescribing the drugs which people have been fighting openly. So practically what were you doing? You had completely knocked up the bacteria of the nose. You have given antivirals, other things which may be there, so you have given a free run. Along with it, when you are seeing there's a huge load of virus in your nose, it has altered the hemostasis, and it has been working on glycolytic, non-glycolytic anaerobic pathways. And along with it, you're giving zinc. Then you are having an unsupervised use of corticoids. What will it lead to? It led to mucor, and then also repeatedly wearing those poor masks or infected masks, repeated reuses, and also more than oxygen, it was the prongs which were not cleared. If there are a lot of people looking at it the way things are, I think combination of factors led to it. If you see the last year data also, we saw double the amount of cases of mucor from period of 1st September to 31st of December. So
what this time, sir, was the use of nebulizations. First wave, we never used nebulizations, but then second wave, we have used a lot of steroid nebulizations.
So that has been responsible to an extent if you're using steroid things. Most of the time, you see these fungi are ubiquitous and people have been inhaling it, doing it. There has to be a competition local because you have just knocked it off everything. So people don't know, but diabetics, we know it. Steroids misuse, we know it. It has been happening. So nebulization, especially steam inhalations, people are trying to put into it, but all conjectural, not definitive. They're all proposed suggestive viewpoint. But my viewpoint here is very clear that we do not need liposomal amphotericin for everybody. It is required in two conditions. If you have a cerebral involvement, brain involvement, one. Somebody, secondly, is having any reaction to the amphotericin deoxylate, and third is kidney failure. These are the three group of people where you need liposomal, not otherwise one. Yeah. Secondly, even if somebody has, if you see it in, so right, left, the cost of the treatment is jacked up. And when suddenly you require a drug for minimum 15 days, and then you add up a posaconazole, or now isoconazole has also come. Costs have been so much. So my suggestion is that we need to have a war reserve with us, which is reasonable amount. Looking at it, what you do expect in third is the lessons. I would definitely like to have a good stock of steroids. I would like to have a good assurance, continuous supply lines with minimal turnover times for oxygen, whatever the plants we may put up, because they may generate up to a limit, they have a capacity. So they will only can supplement LMOs, or you may have to very joint PSA plants or joint oxygenators, which have to be there. And third is very well trained people, and you have to do a triaging. And triaging, you will be surprised this time. I did the unthinkable. We refused tocilizumab as a policy in the peak when we only had availability of 106 vials for the whole set in public and private. And we rationed it above the people of 70 years of age. It was painful, but it had to be done because people have been trying to use tocilizumab right, left, and center. Now, get ready now for tuberculosis upswing. I think that is extremely important now. We are seeing it because after urinocerebral, we saw a lot of cavities in the lungs. When we looked at it, it was mucor, it was and now we are seeing tuberculosis coming up because what we have done, we will now be seeing it, the right-left use of itolizumab, bevacizumab, and other drugs. So my request to all the people will be, if you want to use it, use it, but preferably in a trial setting, not other. And we need Dexa or methylprednisolone steroid stocks with us.
Your take on, sir, convalescent plasma?
Convalescent plasma today, we were very hopeful. Now we need to know exactly how much is the titer required to neutralize. That is why now people, instead of a CPT, are now going for hyperimmune serals, which is nothing as monoclonal antibodies, especially you've done it. So you need to use it as an antiviral early. And when you want to use it early, in the first week, preferably once it is there. Later on, it is of no good use.
Yeah, Dr. Dhruv, at the limitation of time, I think you brought that very interesting topic of the immunomodulation or immunosuppression or effect of this multiple cocktail of playing with our immunity, which actually triggered a lot of tubercular patients which are flowing to us. Even as you said, not just mucor, but a CMV reactivation is seen, some helminthic infestations has been seen. Those all been added challenge, which we may be facing not after the second wave, maybe after the waves. So I think with the limitation of time, what an interesting phenomenon we had today, interacting with both from the national faculty side and with the local side. And it is my pleasure to actually wish Dr. Kamlesh, it was his birthday. So wish you a happy birthday, sir. Wish you a very healthy and happy life.
God bless you, dear.
Thank you, sir.
On his birthday, he took us just time out of his family celebrations, and he was with us to actually enlighten us and discuss, interact with us. So I think with the both experts predicting somewhere from August to September, in that period, we may get a wave where there will be maybe a rise in cases or surge in cases, and we may need to take all the precautions how we were prepared in the first wave. And not just from the medical fraternity, from the common people and the government official, everybody has to be prepared in the same way what we did in the first wave, not doing those mistakes what happened in the second wave. And we need to be prepared ourselves from all angles, as triaging, medication, oxygenation, and all these areas. And we are hopeful that with existing vaccination program ongoing, if we motivate and vaccinate good number of population, maybe our hospitalization severity may not be as big as second wave, and we can tide over. And the apprehension of pediatric population getting more affected has not been seen in the other part of the world. So I think with these information and the medications we have, as both of them has concised, we have come to some understanding and learning with the all wisdom of the last two waves, that the few 3 or 4 medications are been a part of it. With this, I think I thank Dr. Dhruv, who has taken out his time from his all personal challenges and brought us this interesting interaction and debate. And I thank Dr. Kamlesh for his time.
Thank you.
Both has been in the busy schedule. Thank you all the participants for the time and interaction. I thank all. Thank you, sir.
Venkat, I would simply say, be careful, be vigilant, be watchful, and make protocol and get yourself trained. That's how the armies do it. Have a mindset of armed forces. Keep cool. Be there. Hope for the best. Ready for the worst. And keep strategic reserves like war reserves are there to handle it.
Thank you, sir. Thank you. So kind of you. Thank you, Dr. Kamlesh. Have a nice day. Wish you again a happy birthday. Enjoy your birthday, sir.
Yeah,
and have a nice day.
Okay, sir.
Happy birthday, doctor. Thank you.